CD5 expression in a B. We'll just quickly am I audible? And is my screen visible?
Yes, sir. Audible and visible, sir.
Thank you. Thanks a lot, Dr. Adivarsan. Right. So we'll just quickly finish off the assessment cases before we go ahead for the today's lecture. So this is the first case, and I'm just going to discuss the PDF, which has been all given to you. So first is the time plot to check for stable acquisition, then selecting only the singlet population for further analysis. Then you select the viability gate, excluding the population which is having low forward scatter and side scatter, which are debris. And then once you select the viable population, then you look at side scatter CD45, which I've not shown here, but still. So side scatter CD19 shows a B cell population. And once you get the mature lymphocyte population across CD5 and 19, you see a 19 positive population, which are B cells, and a 5 positive population, which are T cells, and a population which are double negative, which could be likely NK cells or some amount of monocytes that has been included in the gate. Okay. Now, if you see this population, like this is quite abnormal. You find a big expanded population, which is showing a variable CD5 expression. Okay. So you find the expression of CD5 starting from the negative zone and goes up to a dim CD5 region. Okay. So you find CD5 in a pattern of dim to negative, and it is homogeneous. You don't see it as in a small subset where it is normal to see CD5 expression in a B cells in a small subset. For example, if you find a big cluster sitting here, say around some 90% and some 5%, 6% shows a small spraying of CD5 positivity, then it's fine. But here, it's not the case where you find that expanded B cell population showing CD5 as a whole cluster. Okay, and it is the intensity is from negative to dim. Okay, and in fact, it is more expanded in the dim region, which is quite abnormal. So we are dealing with an abnormal B cell population, which is expressing CD5. Now, it is CD23 positive in a very moderate fashion. Okay. And yeah, so you can also say variable. So it's positive for 23 in a variable fashion. So now you have 5 positivity and a 23 positivity in a abnormal B cells. Okay. So automatically my diagnosis goes to chronic lymphocytic leukemia. Okay. Let me check whether the other markers are supporting them. Now coming to the same population, as we saw, it is expressing 5. So whenever you are doing a CLPD analysis, or in case, as I said, you ever, any analysis, try to dissect out all the possible normal residual population. Okay. Now T cells we have isolated, but if you do a careful analysis, you can still get out the normal B cells. I don't know how many of you achieved this. Okay. So if you have achieved this, then you got full mark. Okay. Because why the importance of getting that small B cell population out is that it will act as a control for interpreting the markers. Okay. And it can also act as a check for your kappa lambda, whether kappa or and lambda is added into the tube. If you're not doing a cocktail. See, I have experienced where once one case was reported as clonal B cell population, and it was given to us. Then when I went and saw, it was quite surprising because it was a clonal population. For example, I suppose it was lambda restricted, but it didn't show any abnormality. Any abnormality. For example, it was not showing any 5 expression. It was not showing any 23. It was not showing a bright 11C or a bright 200. It was typically fitting with the normal B cell population, except the fact that it is clonal. It is not expressing kappa, and it is completely lambda positive. Now, this population, if you see, sometimes what happens, then when I just inquired with the technician, asked him to repeat, then he repeated the test, then you found the two populations splitting in kappa and lambda. Okay. See, because sometimes your kappa will be showing too much of signal, or your lambda will be too weak, so that you cannot divide only with lambda. You cannot divide the two populations, which is lambda positive and lambda negative, if kappa is not added. So it's always better you try to dissect out that small residual normal B cell population, which will act as a control for all these things. First, it will help you to interpret the markers correctly, the intensity of B cell markers, and then it can also help you as a guide to check your kappa lambda and also draw your hinge gate. Okay. So CD5 is expressed, then 10 is negative.
Sir, one doubt, these B cells, why are the CD10 positive?
Yeah, that could be some reactive, but I agree with that. But yeah, see, there are some amount of plasma cells also in that. It's not completely B cell, mature B cells, right? You can find some amount of population which are expressing CD38 prime. Okay, but CD10, yeah, that's somewhat unusual, but still, when I just get it, there is some plasma cells also into that.
So can be that hematogones? No.
Hematogones, yes, quite. Hematogones, the pattern with hematogones, it can be transitional B cells. Okay, so the answer is transitional B cells. Hematogones, stage 1 and stage 2 will not show you kappa lambda. Is that right, Dr. Shaini? Stage 1 and stage 2 hematogones are immature cells which will not show kappa lambda. Your stage 1 and stage 2 hematogones will fall in this area. Okay, now this is transitional B cells. Transitional B cells will show 38, and they can show some amount of 10 because they are just out of stage 2 to transitional B cells. Or I could say like stage 2 to stage 3, something like that. So some amount of 10, remnant 10 may be there.
Okay.
Right? Is there any other question? Dr. Arivasan, you had a question? Someone was trying to ask a question or something.
No, sir.
Nothing. Perfect. So this is transitional B cell. So you try to get out that normal B cell population. Okay. Now 200 is quite good positive, almost a bright positive 200. And 20, see, this is the beauty of getting this normal population out. When you compare it with this B cells, you find 20 is very slightly low compared to the normal B cells. It is not the bright population. If it's bright, it should fall somewhere here. Or it is not moderate to fall with this population, but it is slightly downregulated. If, for example, if you have not gated this population out, then I would call this definitely as moderate. So that is the use of gating out the normal B cell population. Okay. And this is not plasma cell. I'm sorry, it's not plasma cells. Okay. And 200 is bright. Kappa lambda, you find kappa restricted, but it is dim. Okay, kappa is dim. And then it is almost around 64.9%. So some markers, so 43 is not there in the tube. But of course, now with these markers, we can make a good confident diagnosis. I would love to have IgM, which is not there. Okay, even some other tube has not been given to you. It was FMC7 negative. Okay, it was FMC7 negative, and IgM was not processed, I suppose. So this is a case I got from someone for an opinion. So yeah, so now coming to the diagnosis, let's summarize this case. So we have a clonal B cell population, which is kappa restricted, of course, in a dim fashion. It is expressing 5 in a dim to negative fashion. It is expressing 23 in a variable fashion. 200 is bright. 20 is slightly downregulated or slightly dimmer in expression compared to the normal B cells. Okay, so with this, so we have a 5 positive, 23 positive B cell NHL, and of course 200 bright positivity supports it is a case of chronic lymphocytic leukemia. The other points which are supporting chronic lymphocytic leukemia is the dim light chain, kappa light chain expression and slightly downregulated 20 expression. So the diagnosis is chronic lymphocytic leukemia. So quite an easy diagnosis, but I would be more happy if you have gated out the normal B cell population in this case. So any doubts with this case? Any doubts?
No, sir.
Perfect, super. How many of you gated out the normal B cell population? If you've done
the
it.
plot only.
Sorry? Oh, I showed. Okay, you have seen the plot, so you have not did the analysis by yourself. That's fine. Okay, now let's go for the second case. Second quiz. Now again, so the viable gate, the singlet gate CD side scatter versus CD45. And once I gate the mature lymph population and gate it across CD5 versus 19, I find a normal T cell population and a B cell population. Okay. Then if you find gating it across 1920, you find it is almost right for 19 and 20. Okay. It is expressing 10, of course, in a dim to negative fashion. And then when you check with kappa lambda, you find that the lambda population is increased compared to the kappa population. So I get the lambda population. And when I go back, I can find that the expression of this population is bright for CD20. Okay, you find the population in sandal color is normal B cells. Okay, and you find the lambda restricted population. Yeah.
Sir, why is it kappa only restricted, that normal orange color?
No. The problem is that, see, there is normal, some amount of normal B cell population within this particular gate, but I could not bring it out at this stage. You got it? So this is normal kappa expressing B cells. There are also normal lambda expressing B cells along with the neoplastic lambda restricted cells. But at this point, I cannot bring it out from this particular cluster. I need some other markers of this particular, for example, now we know this is a case of hairy cell leukemia. So I need some markers like 11C or 200, 123 to bring out the normal lambda positive B cells out of this. Okay, but at this juncture, I cannot bring it out. So it's not completely neoplastic, but a small percentage of normal lambda positive cells are there in this. Okay. Why I'm getting this particular population? Now this will act as a control for me. I'm very damn sure like this is normal B cells because there is a skewed kappa lambda ratio. The lambda population, normally the kappa will be more compared to lambda. But in fact, without that, the lambda population is skewed. There is an expansion on the lambda population. So I know the neoplastic cells are lambda restricted. So to take some B cells as control, I've highlighted this particular events. So with that, I can say like the neoplastic B cells are 20 bright. Okay. So some amount of red events will be fallen here. Since I've made this events bigger, it is not clear to you. So if you find some red events will be falling in this area, the lambda positive normal B cells will also fall. Some red events will fall in this area. Since I have made this events as larger, it's not been visible. Okay. So now it's 20 bright. Again, it is 19 bright. And as I said, 10 is dim to negative. And you find that this red color population, or the population is falling in the monocytic region. So whenever you have a neoplastic B cell population falling in the monocytic region, you have what all differential diagnosis?
Hairy cell, Burkitt.
Yes. So hairy cell leukemia variant, or hairy cell leukemia group of B NHLs, and then Burkitt. Okay, so this is the typical location of monocytic. The typical monocytic location of these particular BNHLs, which is hairy cell and Burkitt. Okay. Now let's go for more specific markers. So now this is 79B and 19 positive, of course. And this is the plot which will clinch you the diagnosis. So whenever you find 11C bright, okay, as a homogeneous bright population, then you are dealing with a case of hairy cell leukemia or a hairy cell leukemia variant or a splenic marginal zone. Okay. So normal B cells will show predominantly 11C negative with a small trail which will be showing 11C positivity. Okay, as a small, I mean, like you have predominantly negative population, okay, and you have small population which will be 11C expressing in a variable fashion. So that is a normal pattern with 11C in normal B cells. Whereas you find here, the population is homogeneous and right for 11C, and in fact, it is positive for 103. Now, since it's 103 positive, splenic Marshall zone is less likely. We need to differentiate it from hairy cell leukemia or an hairy cell leukemia variant. Okay. It is 25 positive and 123 positive, which confirms that it is hairy cell leukemia and not hairy cell leukemia variant. Okay. So 25 positive and 123 positive. So 123 positive and 103 positive. 200 is bright. FMC7 is also bright positive. Okay, so now what are the lymphomas which are FMC7 positive? Other lymphomas, just like that, for some examples. Common FMC7 positive lymphomas. Common.
Non-CLL, hairy cell, all other non-CLL types.
Yeah, so basically mantle cell lymphoma, okay, then follicular lymphoma, okay, hairy cell leukemia. Okay, so these mostly, yeah, as non-CLL, but these three commonly show FMC7 positivity in a good fashion. Okay. Then you have 180 positivity, but which is more for margin zone, but still, okay. So any other new markers? It's negative for gamma delta and all other T cell markers. Yes. Yes. So it's a very simple case. It's a case of hairy cell leukemia variant. Sorry, hairy cell leukemia. Excuse me. It's a case of hairy cell leukemia. Right. Any doubts with this case? Any doubts? Very easy case, right? So it's a very easy case. Well, let's go for the case number 4. So case number 4 is basically not. I'll tell you. It's, of course, you would have seen the case. It's a case where there were some few plasma cells in the marrow. There was a small M protein on electrophoresis. Of course, the patient did not have any clinical symptoms. Okay. Except the patient had some mild renal impairment. Yeah. So this is the case. So we just, in view of some plasma cells seen in the marrow and with given history of M protein increase and a renal abnormality, we just went and proceeded with the myeloma tube. So this is a viable gate, then singlet gate, then site scatter CD45. So initial gate for plasma cells, normally I use a site scatter because CD138 is expressed in plasma cells, true, but it can be downregulated by time. Okay, so as time is, I mean, with increasing time or with the delay in sample processing, CD138 may go down. So my initial gate will be site scatter CD38, where I draw a very broad gate, including all the populations, including some amount of hematogones, monocytes, etc. Then I purify this particular population with 38 and 138. So any population which is 38 positive and 138 positive or dim, even 138 is falling in this region, anywhere here, even I'll include that into the gate. After doing that, I need to check. Now I've gated the entire plasma cells. Okay, still you can refine the population with site scatter CD45 and so on. So, and after gating all the plasma cells, I'm going to check for any abnormal phenotype in these plasma cells. So as I'm checking, as I told you during the lecture, check it across all combinations. CD56 versus 38, 45 versus 56, 19 versus 38. Okay, so 27 versus 38 or 27 versus 56. So you just check with all the possible combinations so that you can able to pick up the abnormal plasma cells. So this is something like an MRD detection in myeloma. Okay. So once I get it across 56 and 38, I get two clusters. One cluster is 38 right, Okay, and 56 negative, and the other cluster is, of course, 38 bright, but slightly lower than the normal plasma, cells which are not expressing 56. And you find the other population which is expressing 56 and 38 slightly lower than the population which is not expressing 56. Okay, not great, but still slightly. If you just see, slightly lower. Okay, then checking with other populations like CD45 versus 56. 45 is not much helping, but you find this population 56 positive. Okay, but who's the ultimate decider? The ultimate decider is a kappa lambda plot to confirm it is abnormal or normal. Okay, so but for the time being, we'll just call this as abnormal plasma cells or cells with abnormal myeloma associated immunophenotype. Okay, and this population is normal plasma cells. Okay, so you find this particular population is expressing 200. Okay, but this 56 expressing population is expressing overexpressing 200. So that is again MAIP, that is myeloma associated phenotype. You find this population expressing 19, but you find this population which is showing down-regulated 19. So which is again in myeloma associated immunophenotype. So we have 3 phenotypes till now, like 3 MAIPs. And then the same thing, 19 and 200 is helping us. So let's check with any other marker like, so same 38, 138, and you find 81 is also helping. So the population expressing 56, the highlighted in red, is also down-regulated for 81 compared to the 56 negative plasma cell population. So now we almost have 4 myeloma-associated immunophenotypes, 19, 56, 81, and what else? 19, 56, 81, and
200.
200. Perfect. 200. So we have 4 MAIPs. Of course, 38 slightly low. Again, can be taken, but bit deceptive. Some people may not agree that. And you find here 45 is down-regulated. One tube was not showing that. I don't know, but still, here you find the 45 is down-regulated, which adds 5th MAIP. And 117 is expressed in the abnormal plasma cell population. So which is 6 MAIPs are there. 6 abnormal phenotype markers are there to confirm that this is almost a neoplastic plasma cell. Okay. So you can see again one more abnormal expression, which is down regulation of CD27 compared to normal plasma cells. Okay, you find 27 is down regulated in this population compared to this population. Okay. Okay, so same things. 117 is positive, 81 is down regulated, and finally this is the plot which will confirm whether it is abnormal or normal. So when I get the blue color population which did not express any abnormal myeloma associated phenotype, it splits into 2 in kappa lambda, and the ratio is quite well preserved, which is 62% kappa and 36% lambda. Okay, but when I do the same for this abnormal population, you find it is predominantly lambda restricted and only few units in the kappa. So the kappa lambda splitting is skewed, distribution is skewed, which confirms that this is a myeloma associated immunophenotype. Okay, so these are some normal B cells. So just get it across kappa lambda, which are splitting into 2. So what can I confirm by this? Why have I gated the normal B cells and drop it in kappa lambda and to check whether it is polyclonal or clonal? Well, why am I doing this plot and what is the purpose of giving this plot?
Comparison
Sir,
of
for
the ratio.
prognosis.
Prognosis. In what way it is going to? Yeah, it helps you to rule out
LPL.
Yeah,
LPL.
it helps you to rule out LPL, lymphoplasmacytic lymphoma, because you have only small percentage of clonal plasma cells. Okay, but even though if I have not given this plot, can you able to differentiate? Even if I have not given this plot, or I have not shown you whether the lymphocyte is clonal or the B lymphocytes are clonal or non-clonal, Okay. Can you able to whether rule out Waldenstrom's or LPL in this case?
Here plasma cells are abnormal.
Excellent. So the plasma cells here are abnormal. In Waldenstrom's, the plasma cells will be showing normal phenotype. They'll be clonal, but they'll show normal phenotype. In contrast to this case, so LPL plasma cells will be clonal. That is, it will be either kappa restricted or lambda restricted. But these plasma cells will not show loss of 19. They will be 19 positive. They will not show 56 expression. They will be negative for 56. They will be positive for 27. They will be positive for 81. They will be negative for 117. So this abnormal phenotype will not be expressed by the LPL plasma cells. Okay, so only they will be clonal. That is the only abnormality you can find, right? So that's correct. So now what is the diagnosis for this case? I gave you an history. So this is the phenotype. So by this flow, you say that there is a clonal abnormal plasma cells against some normal plasma cells. And I given you a history that this patient had no symptoms. Okay, only thing is he had a small M protein and he had some renal abnormality. For example, creatinine slightly elevated. Now, what is your diagnosis?
MGUS.
Sorry?
MGUS.
Okay, see, when you're calling MGUS, you're almost right. But the problem here is MGUS is monoclonal gammopathy of undetermined significance. And the criteria for MGUS is he should not have any end organ failure or any organ disability. Like he should not have any CRAP criteria. Okay, or end organ damage or something like. Now, this patient has
monoclonal gammopathy of renal significance.
Perfect. That is the answer. So this is a monoclonal gammopathy of renal significance because the renal impairment has been documented. So this is MGRS. Okay. So this case is an MGRS. But I don't expect you to give this as a diagnosis in your results because I have not given you the history. So without history, this case cannot be labeled that. So that's fine. So the people who have given it as abnormal plasma cells, I'm fine. LPL is not acceptable.
So here, what is the green population? Down.
Green should be hematogones by scatter. Yes, it's hematogones. It's hematogones, HGS. I have not shown you that. I should have shown you with 10 and 20 or something, but this is hematogones. By pattern, I can feel that it's hematogones. So with respect to here, it is hematogones. Because see the scatter, very low side scatter. And you can also find this small population, which could be stage 1. This is stage 2 and stage 3. So that is hematogones. So can we go for case 2? Any doubts with case 4? Perfect. Now case 4 is interesting. Okay, now, so this is a case which I've given you. So singlet, then viable gate, and you find an abnormal population. Of course, not with this plot, but I've given you the plot which is representative to get the diagnosis. Okay, now you've gated the CD45 mature lymphoid population, and when you gate it across, I've not shown you a very sequential gating. I've just shown you the T tube. In the T tube, that cells what you've gated, predominant of them or 92% of the lymphocytes are co-expressing 16 and 56. So the cells which express 56 and 16 is commonly a NK cell, correct? So you have an expanded cells which are showing more like an NK cell phenotype, 16 and 56 positivity. And when you gate it across 4 and 3, you find that the predominant of this 16 and 56 expressing population is CD3 positive, 4 negative. So if it is CD3 positive, then it cannot be NK cell population. The other possibility could be a TNK cell population. Okay. So TNK population, expanded TNK population. Okay. So that is the diagnosis which is from this plot. Now 3 and 56 again. So 3 is positive. So TNK is a population. And then 3 and 16 again, it's co-expressing. That's fine. It is 7 positive Okay, so which is not going to make my diagnosis away from T and K. Still, I more feel it could be T and K. And what I'm doing is independent flow cytometry. I'm not seeing the morphology. Okay, so T and K, 7 is positive, 3, 7 is positive, 5 is negative. Now, this is something away from T and K. Correct? Because T and K cells should also exhibit CD5. Now, this population, which we thought it as T and K, now is not showing CD5, which is something abnormal. So, are we really dealing with T and K cells? Because T and K cells should show some CD5 expression. Here, it is completely negative. So, checking with other markers, it is expressing CD8, of course, in a dim fashion or negative to dim fashion, which is fine. So, CD8 is positive. And 57 is negative, or it is not showing that clustered positivity, only some spraying. So, and predominantly it is negative for 57. So, when 57 is negative, what diagnosis I can remove?
LGL.
Yes, TLGL is ruled out. Because 57 TLGL is 57 positive, now 57 is negative. So, TLGL is ruled out. So, this 5 is again is not to the pattern of TLGL or TNK cell leukemia, and absence of 57 still confirms that the possibility of TLGL is very unlikely. Then when you see the other plots, you can find that this population is TCR gamma delta positive. So the neoplastic T cells are gamma delta positive. It shows T cell markers CD3 and 7, whereas CD5 is lost. It is co-expressing 16 and 56. Okay, and CD57 is negative. So, what is the diagnosis?
Hepatosplenic gamma delta.
What is the diagnosis?
Hepatosplenic gamma delta T cell lymphoma.
Okay, so gamma delta T cell lymphoma. Okay, any other diagnosis for discussion?
Sir, actually, I initially kept it as LGL because
Yeah.
I overlooked 57.
Yeah.
And because the cells were large and they had high side scatter, so I kept the diagnosis of LGL.
Okay, so you finally kept the diagnosis of LGL. Like,
initially, I kept
LGL. Yeah, it's a good differential. I would definitely be happy if a differential of LGL has to be kept. I mean, if not kept, like LGL is a good differential for this case. TLGL especially.
Cells are actually having very high side scatter.
Yeah. No, you need to understand that you can't go with the side scatter much because I suppose it's been shown in a log scale rather than in linear scale. But still fine, no problem. That's fine. But see, two things away from LGL, TLGL is lack of CD5 and absence of CD57. This is unusual with TLGL.
Actually, 57 in the graph you showed was plus minus, so I thought it can be negative also. But
Okay.
5 is always positive.
No, but commonly, see, your TLGL will commonly show it. Plus negative means it will be like dim to negative or something. It can't be like predominantly negative like this.
Okay.
And absence of 5 is again against TLG. Okay. So the diagnosis for this case is, of course, gamma delta T cell lymphoma, which is a very, 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 very rare case. So I don't know how many of you have seen a case. So this is gamma delta T cell lymphoma, and I just want to show you a slide. So I'll just stop the screen sharing and I'll go to the presentation. I'll come back just a minute. So if you see, I suppose my screen is visible. If you see this case, see, this is of course a case of hepatosplenic gamma delta T cell lymphoma, and the phenotype perfectly matches as given in the literature and the books. So it is 2 positive, 3 positive, 4 and 5 negative, 5 negative. Okay, 7 for the 7 positive, 8 can be dim positive, 16 and 56 are positive, 57 negative, and it is gamma delta positive. Perfectly fixed with this. Okay, so it's a case of hepatosplenic gamma delta T cell But you also need to know that sometimes 8 can be negative. still it does not rule out the diagnosis of hepatosplenic gamma delta lymphoma. And similarly, 16 can be negative, or at rare cases, 56 can also be negative. So 1656, don't think if you get a population, that is the importance of having a good panel. Now, for example, if you want to use a very stringent panel and you are not using TCR alpha, beta, or gamma delta, and in fact, if we are not using gamma delta and alpha, beta, or we definitely will not use 57. So then you will be caught up and you may think, what is this case?
So in case 9, what is in this panel? Case 9, it is showing CD5 negative in T cell LGL.
Sorry, come again. This one.
Case 9, yes.
Yeah, I agree. This is the one. So this is TLGL, gamma delta TLGL. This is gamma delta TLGL, not the regular TLGL. Okay, this is gamma delta T cell LGL. 57 is positive. You mean to say still it can be negative?
CD5 is negative. CD5 is negative in this.
Yeah, CD5. What I would say is the commonest condition. Still, to report in literature, you can report. They might have got some other clonal thing or something to report, but commonly TLGL is 5 positive. Okay, you may get that rare case which is 5 negative, but always commoner things are common. Okay, so still if it's in a TLGL, then the catch is with 57. So if 57 is positive, then the likeliness of hepatosplenic gamma delta T cell lymphoma is unlikely. So again, that is what I say. Whenever you are analyzing a case, don't get biased by 1 or 2 markers. You just see completely with all the combination of markers. And when putting the diagnosis, take every marker into consideration and then pen the report. Now, as you rightly said, yeah, this is one that rare case where CD5 is not expressed in gamma delta T cell TLGL. Okay, now see, again, I'm telling you, this is not regular TLGL. This is gamma delta T cell LGL, which can show loss of CD5. Okay, because gamma delta T cells can show loss of 5. Correct? You're getting my point?
Yes, sir. So we should consider both CD5 and 57.
Exactly. This is one such case where you need to. That's what I'm saying. Morphology has to be taken into consideration. But if you're doing an independent flow of phenotyping, I would be happy if you have given a differential of 2 things. One is gamma delta T cell, hepatosplenic gamma delta T cell lymphoma and gamma delta TLGL. But of course, 57 is not there, but still 2 differentials is much safer for you to give the final report. And then you go and check in the morphology. If you have a blastoid morphology, then it more favors an hepatosplenic gamma delta T cell lymphoma. And if you have granules with indolent cells, it more favors gamma delta TLGL. Right? So this
does side scatter helps in just a question?
Yeah, side scatter will definitely help in LGL because of the granules which are present in the cells, but it is not diagnostic.
That I agree.
Yeah, you have some other cells which may have some small vacuoles, even that can show high side scatter. So side scatter, it's something like I would always take it at last.
Yeah, actually, I took that just to differentiate in the last.
That's fine. But the most important catch in this case, so this case was given to you to discuss about gamma delta T cell malignancies, which I didn't cover much during our theory session, or I didn't show you a case during our live gating also. So this is whenever you find a neoplasm, of course, a mature neoplasm, when it is showing a gamma delta positivity, always have this markers and try to put it in the correct diagnosis. Okay, so you definitely need gamma delta in your panel because you may get that one rare case of gamma delta positivity. Okay, so if you're not using it in your panel, you will miss it out. And always check 57 and other markers when you are having a gamma delta positive T cell neoplasm. Okay, I have seen TALL, gamma delta positive TALL cases. Okay, something like alpha beta, it's again another T cell receptor. So it can be expressed in neoplastic cells. So, but in ALL, TCR, gamma delta, what is its significance? I don't know. I've seen around some 6-7 cases where it is gamma delta positive, acute, a TALL with gamma delta positivity. But I have yet to see what is its significance. From the literature, I understood that there is no any important significance as like ETPLL or other types. But since it's in my panel, that's just a finding. So any doubts with this case? Clear, right? So when you get a gamma delta T cell malignancy here on, so it would be easy for you to give the diagnosis. So with that, we'll go for today's class. Okay. So today's class is about T cell MRD. So we discussed about B cell MRD last week, and today is T cell MRD, TALL MRD. The good news is that it is relatively easier than BALL. Can anyone say the reason?
Because maturation is not in the bone marrow.
Yeah, maturation is not important here because you don't find immature cells in the marrow, immature T cells. You don't find immature T cells in the marrow, and you don't find immature T cells in the peripheral blood. Okay, the problem with BALL, what we had is we have normal immature precursors in the bone marrow, which are called hematogones. And the ultimate task for you lies on differentiating your immature leukemic cells from these normal immature cells. Whereas in T cell or T cell ALL MRD, you don't have that problem because you don't find normal immature T cells in the marrow, since the T cell maturation happens in the thymus. So that is the beauty of T cell MRD, which is relatively easier than BALL MRD. If you want me to classify the MRDs based on complexity, the most easiest is TALL MRD. Then comes BALL MRD. And finally AML MRD. AML MRD is tough. Okay, of course, myeloma MRD is also easy. If you ask me, I would say apart from AML MRD, all other MRDs are quite easier. AML MRD, you need more expertise, more practice. You need to know. The problem is AML is a very heterogeneous disease. You find the myeloid cells differentiate towards erythroid, megakaryocytes, basophils, many lineages, right? PDCs, and so on, so. So you need to know the different each maturation patterns. In contrast to BALL, where it's a simple maturation pattern, and in TLL there's no maturation patterns needed to detect the MRDs. Right. So this is about repetition of last lecture. So I'm not going to go very deep into it. You know what is MRD? So it is detection of leukemic cells, which is below the threshold of basic microscopy, and like whatever you feel that the patient is in remission by morphology, that is less than 5% blast in the morphology, still 20 to 30% of such cases may have disease and they may relapse eventually. Okay, and MRD is used to check the effectiveness of the treatment and predict the risk of relapse. And I suppose now you would have asked your clinical colleague what protocol is being used and what is your MRD cutoff. Okay, so the MRD cutoff, to call it as positive and negative, depends upon the protocol what is used. Okay, so this all I already discussed. So MRD positive always has a better outcome compared to MRD negative. MRD positive has a poorer outcome compared to patients who are MRD negative. And patients who are consistently MRD positive, that means like you need to go for a second line or an alternate therapy. For example, like you can take up the patient for bone marrow transplant. And so if you're taking a case for BMT, if it is negative, it has much more better outcome than those cases taking for BMT with MRD positivity. And again, see, cases who have achieved CR can be MRD negative or MRD positive. And if you're not doing MRD, some of these cases can directly end up in relapse. But if you do an MRD positive, then you discuss, you can give an augmented therapy and still bring it back to MRD negative. Okay, so this all I just discussed last class, so I'm not going very deep into this. This also, so timely intervention of timely doing of MRD and then intervening with alternate therapy can bring down the relapse. Okay, or if it's not done, then there can be a full-blown relapse, which is fatal. And the time points of assessment, post-induction, which is a very, very important time period for MRD assessment, and this gives you the overall survival and event-free survival. Cases which are positive at post-induction tend to have a relatively poorer prognosis compared to those who are post-induction MRD negative. The other time points, it's post-consolidation, maintenance, end of treatment, before stem cell transplant, after stem cell transplant, and other areas where the patient is having cytopenia or not recovering counts, then you can again just to check whether the patient is going on the right track, you can do the MRD. And the methodologies, flow cytometry, PCR, and NGS. The beauty of flow is currently for ALL, the method of choice for doing MRD is flow cytometry. For AML, yeah, of course, flow is helpful, but the other techniques are also needed because flow is not 100% as in ALL for AML in detecting MRD. Okay, but the problem with PCR and NGS is that you need the baseline sample. That is the diagnostic sample. You need to work on the diagnostic sample and need to know what is the T cell or the immunoglobulin rearrangement which is present in the neoplastic cells at the diagnostic time point. Only using this signature, you can detect MRD at the other time points. Okay, whereas in flow, if it is available, it's fine, it's good. If it is not available, still we can detect MRD by the DFN approach, different from normal approach. You know what are the approaches, right? For B-cell MRD, LAIP approach and DFN approach. So sample for MRD detection, like it can be bone marrow or peripheral blood. For TALL, peripheral blood is equally good as marrow, but still the practice is marrow. But peripheral blood is equally good as marrow in TALL, which is not the same for BALL. BALL, it is always marrow, which harbors higher burden of disease because the B cell development happens in the bone marrow in contrast to T cells where the development happens in the thymus. Okay, so make it simple. For BALL, it's always marrow. For TALL, marrow is good. If you don't have the marrow, then peripheral blood is fine. So now coming to, if you see the post-induction positivity rate in TALL, it is around 43.75%. So if you take 100 cases of TALL, almost 50% will be positive at post-induction point of view after 28 days of chemotherapy. Okay, and almost of which, I mean, of TALL cases, around 36.69% or 37% will show MRD greater than 0.01%, which is MRD positive by the clinical cutoff of BFM protocol and I-cycle protocol. Okay, even at consolidation, there may be positivity around 33% in post-consolidation marrows. And again, the percentage is slightly higher. Okay, which is MRD positive greater than 0.01 in 26.8% cases. Okay, so if you take it up, post-induction positivity for T-cell ALL, post-induction MRD positive for T-cell ALL is slightly higher compared to post-induction positivity in T-cell ALL. Okay, so that is important. And T-cell ALL can take a slightly higher time to clear compared to B-cell ALL. Blast clearance. Okay, the blast clearance in T-cell ALL will take a bit longer than blast clearance in BLL during the induction treatment. And this is the normal T-cell maturation. Okay, so I have just discussed this during our diagnostic class as well as so in the diagnostic class. So you see the T-cell maturation as 45 starts from the early prothymocyte stage up to the mature T cells. And you know, this is all happening in the thymus and not in the marrow. Okay, so the immature stem cell from the bone marrow comes and settles in the thymus where it gets signal to differentiate into T cells. Okay, so CD45 is dim in prothymocytes and slowly it acquires and becomes bright in mature T cells. 34 will be expressed in the very, very early T cells. Okay, so if you find any CD34 positive T cells in the bone marrow, you can give it as residual disease with eyes shut. Okay, so I repeat, when you find a CD34 positive T cells in the bone marrow during the induction MRD assessment, you can give it as MRD with eyes shut. Okay, TDT, of course, you know, it is positive during the immature stage and then slowly lost as the cells become mature. 7 will be consistently expressed throughout the T cells as like your CD19 and B cells. So 7 is expressed consistently in all the stages of T cells, starting from the early T cell to the late mature T cells. Okay. And similarly, CD2, yeah, it's like it starts. It's relatively weakly expressed in early T cells, which is prothrombocyte, and then during the T cell maturation, like in the cortical stage or the medullary stage, it is good positive. Okay, and then it is consistently positive. Similar with CD5. Cyto CD3 is again, you find that initially cyto CD3 is low. Okay, cyto CD3 is initially low in the very early T cells, but later it is positive, consistently positive. Okay, now if you want to select cyto CD3 versus CD7, which is the best gating marker with respect to this? CD7, because it is covering the immature population which is not covered by cyto CD3. Okay, so I would love to go for CD7 as my initial gating marker. Okay, CD4 and 8 is initially negative in early T cells. So early T cells will be negative for both 4 and 8. And as they go into the cortical stage or in the medullary stage, they acquire both. So the T cells, every T cells will show CD4 and CD8 co-expression. Okay, so during the medullary stage or the cortical stage, every T cells will show CD4 and CD8 expression. And later, when they go for positive selection, they have to select either 4 or 8. So cells which have selected 4 will lose 8, and cells which have selected 8 will lose 4. And then they finally, as they become completely mature, they'll express either 4 or either 8. So if you find any increased cells, increased population with 4 and 8 co-expression in the marrow, again, that is a sign of immature T cells. If you find a 4 and 8 co-expressing population as a cluster in the bone marrow sample, in the post-induction assessment or any MRD time point assessment, then that is an evidence of immaturity. Okay. Similarly, CD3, it is expressed only in the later stages. Okay. It is almost moderate to bright positive in the mature T cells. It will be weak in cortical or medullary T cells. Okay. Similarly, TCR and CD3 make a complex. So TCR and CD3 expression will be going hand in hand. Okay. So similar expression as TCR expression is similar to CD3. Okay. So this is the maturation pattern. You find the maturation happens like this with CD5 and CD3. And this is all from thymic tissue. Okay. It's not bone marrow. And you find it is double positive, and once if it selects 8, it loses 4 and becomes 8. If it selects 4, it becomes 4, losing 8. And there may be small subset which is negative for both 4 and 8. And similarly with CD45, you find the immature T cells are slightly CD45 dimmer, weaker, and as it matures, CD45 becomes bright. I hope you all remember what I said for 45 expression in T lymphoid blast compared to B lymphoid blast at diagnostic phenotype. At diagnosis, how would CD45 vary between T lymphoid blast and B lymphoid blast? Anyone?
Moderate to bright.
Yeah, so the BL blast can be negative, can be dim to negative, or it can be like moderate to negative or moderate to dim, something like that. Whereas the T lymphoid blast will most commonly be moderate, sitting in the blast gate, and it will be abutting the T cells, mature T cells. So it will be always like moderate to bright, in contrast to B lymphoid blast. Okay. Now, in contrast to all these maturation patterns, when you get a neoplastic blast population, you find it is homogeneous, and you see the CD3 expression. This is normal T cells. CD3 is downregulated. Okay. So that's a sign of immaturity. And similarly, 4 and 8 double negativity. It's a sign of immaturity. And you find the controls here. CD8 positive normal T cytotoxic cells. CD4 positive normal helper cells. And again, CD45 is slightly lower. And as I said, CD3 is weaker. So these are all signs of immaturity. Now, prerequisites, I just said you in the last class, it's always better do an MRD in 8-color mission. You need to have a good experience with leukemia immunophenotyping before you start MRD assessment. Okay, you need a good software. And the knowledge of pattern is not needed basically for T cell MRD compared to B MRD. So I said you what is the reason. So no normal T cell precursors are seen in the bone marrow or peripheral blood, hence no trouble of differentiating the residual leukemic events from normal precursors as in BALL MRD or AML MRD detection. If immature T cells are detected in the BMA or PB, it is MRD. Okay. Now, what is the evidence of immaturity? Now, you do have expression of CD34, okay, a stem cell marker in T cells. Almost, it's as I said, you can give it off with eye shut that it's immature T cells or residual leukemic T cells. Now, 1A expression, again, you know that only in our diagnostic class we discussed that 1A positivity comes in cortical type TAL. So 1A will be lost in normal setting, cortical stage during the T cell development. At the cortical stage, they will be expressing 1A. Once they become mature, or they will lose 1A. So when you find 1A expression in the T cells, it is a sign of immaturity. Similarly, TDT. Similarly, CD99. So these 4 markers are markers of immaturity in T cells. Okay. The other evidences for immaturity is relatively dimmer CD45. You know, like CD45 expression increases as the cells mature. So as I just shown you in the plots heat map, CD45 will be slightly lower in prothymocyte or very early T cells. Then CD45 becomes brighter as it gets mature. Okay. Similarly, CD5 will be relatively lower in expression or relatively weaker in immature T cells compared to mature T cells. Same applies for CD5. I told you that. Okay, CD3 will be expressed only right in mature T cells. It will be weakly expressed in the cortical stage. Okay, and it will be negative in the early T cell stage. So in early T cell stage, it will be negative, and once it matures to cortical stage, it acquires CD3 in a weaker intensity, and then when it becomes mature, CD3 is brightly expressed. Okay, so the expression of cytoplasmic CD3 and absence of surface CD3 indicates immature T cells. Okay, so that is a very, very important plot during our MRD assessment in T cell ALL. So you know that during early stages of T cells, though the CD3 molecules are not put on the surface, they'll be present cytoplasmically. Okay, so when you find a population of cells which are positive for intracytoplasmic CD3 and it is not expressed on the surface, it is a sign of immaturity. Agreed? If you find a cluster of cells which is expressing intracytoplasmic CD3 as well as surface CD3, then it is likely mature. Okay, so this you need to understand. So when you have immature T cells, okay, they have not got surface CD3 on the surface, or they have not got that adequate surface CD3 on the surface. They have good cytoplasmic CD3. Okay, so that is a sign of immaturity. So intracytoplasmic CD3 positivity and absence of surface CD3 or weaker surface CD3 is a sign of immaturity.
So one doubt, some cases, as previously said, can be both cyto and surface positive.
Some cases can
be both sides. Some cases of TALL can be both cytoplasmic and surface CD3 positive. So will that create a problem?
You mean to say it is CD3 positive and intracytoplasmic CD3 positive, both positive?
Yes.
Yeah, it is slightly tougher during your MRD assessment. I'll tell you that I'll be discussing in the subsequent slides how to deal with those cases. You mean to say a problem in MRD assessment or problem in diagnosis? In diagnosis?
No, in the diagnosis, sometimes it can be a problem, but if it create a problem in MRD also?
In diagnosis, I don't think so. You will have a problem because you have a lot of other markers. You have CD5 with you have CD34, you have CD10, and TDT is there. So many things are there. In diagnosis, I don't see it as a problem. Whereas in MRD, yeah, it is a bit challenging, but still you can detect it. It's not like you cannot detect MRD in such cases. You can detect it still. Expression of CD38. See, some immature T cells can show CD38 expression. So whenever I'm putting an asterisk here, that means like you should not take that as a sole evidence of immaturity. So what I mean to say is that you cannot take expression of CD38 alone as a sign of immaturity because activated T cells can show CD38 positivity. Okay, activated T cells, possibly more commonly the cytotoxic T cells, CD8 positive T cells can get activated and they can show CD38 homogeneously expressed. And you cannot take that as a sign of immaturity. So whenever I given you an asterisk sign, okay, you should not take that as a single criteria to determine immaturity in T cells. For example, dim expression of CD3 alone or a dim expression of CD5 alone. Okay, dim expression of CD45, of course, it's good, but still, in contrast to expression of CD34 or 1A or TDT or CD99, which is like even if single marker is present, okay, in a good cluster of cells, then it is quite a solid evidence to take those T cells are immature. Okay, now again, CD4 double positive or double negative, both are signs of immaturity. Okay, but most commonly we get double negative during our MRDs. Okay, so as an LAIP. So double negative is a sign of immaturity and double positive is a sign of immaturity. Correct? The reason I just said you during the development of T cells. Development of T cells, both are negative, and once it goes to the cortical stage, the T cells express CD1A, and at the same time, they also show expression of both 4 and 8. Then they go for positive selection, and CD1A goes down. And then what happens? It has to either select between 4 or 8. So some cells go with CD4 positivity, and some cells show CD8 positivity. So double negative and double positive CD4 and CD8 is an evidence of immaturity. Okay, so gamma delta T cells are dual positive, 4 and 8 double negative, and they can sometimes interfere with your T cell MRD. So you can find some population of T cells which are showing 4 and 8 double negative. But you can easily differentiate gamma delta population because they are CD3 bright. They are surface CD3 bright, and you can eliminate them from further analysis, or you can just exclude them saying like these are gamma delta T cells. Okay. So though I say use so many markers of immaturity, I may not be using all these markers in my MRD panel, T cell MRD panel. Of course, I will use all these in diagnostic panel, but not in the MRD panel. The reason is that the stability of the markers. Because at diagnosis, the blast is almost newly there. It has not undergone any stress or any attack by chemotherapy or so and so. So it expresses all the antigens present on it. Okay, but during the induction, intensified chemotherapy is given and the blast is subjected to a lot of chemotherapy, which can modulate the expression of markers. Okay, so some markers which are initially present at baseline can go negative, can go down-regulated. Okay, and some of the immaturity markers which I've shown here can go down-regulated. What are those? The most common ones include CD99, TDT, okay, followed by CD1A, then CD10 and CD34. So 1, 2, 3, 4, 5. First first CD99, then TDT, third is CD1A, fourth is CD10 and CD34. These 5 markers, I've arranged them in the order of decreasing stability. Okay, so CD99 is very labile, so it can go negative many a times. TDT then can go negative. 1A, again, it is also not that stable marker. 1A can get down-regulated during the induction chemotherapy, followed by CD10 and CD34. So in my MRD markers, I may not be using CD99 for the simple reason that it can go down-regulated. So at baseline, you may find CD99 positive in the blast. But when I do a post-induction MRD and I detect the MRD, that MRD population may not show CD99. Okay. So, and similarly, TDT, second. Third is CD1A, 4 is CD10 and CD34. Okay. So if my tube is an 8-color tube, definitely I will not be using these 5 markers. Okay. Now I've shown you a tabular column where it is showing the marker down regulation, CD99, TDT, 34, 10 at pre-treatment. How many percentage of cases that are shown greater than 20% expression in blast? And how many cases have shown greater than 50% expression in blast? And you can just check it with day 29. You see the percentage of percentage has markedly come down. The percentage expression of these markers in the blast have markedly come down. So that is the reason why these markers are very labile. Okay. So now coming to the gating marker, as I given the simple reason, CD7 is a sensitive marker. When I mean sensitive, it will pick up most of the T cells. Okay. The simple reason what I said you, like, it can pick up from the very early very early T cells to the mature T cells. Everything is CD7 positive. So it's a very sensitive marker for T cells. But cyto-CD3 is more specific. So what I mean to say is that cyto-CD3 will be more specific for T cells. But I will not say 7 to be a very specific marker for T cells, because CD7 can also be expressed in a subset of NK cells. CD7 is commonly expressed in NK cells. It can be expressed in a subset of myeloid blasts. It can be occasionally expressed in a very small subset of PDCs. So 7 is not something which is reserved only for T cells. It can be seen in NK cells. It can be seen in a subset of myeloid blast. It can be seen in a very small subset of PDCs. So CD7 is not a very sensitive marker. Okay, whereas CD7 is a sensitive marker, but not a specific marker. Whereas cyto-CD3 is a very specific marker. You cannot find cyto-CD3 positivity in any other cells apart from T cells. It is reserved only to the T cells. So it is a very specific marker, but not a sensitive marker, because the simple reason I said you, very early T cells maybe, especially in ETP ALL setting, it can be cyto-CD3 weak or rarely negative. Okay. Those cyto-CD3 specific cases that show very dim cyto-CD3, especially ETP ALL, can be missed when you use cyto-CD3 as a gating marker. Hence, CD7, though it is not a specific marker, but it being a sensitive marker, I would use CD7 as a initial gating marker for T cells. Okay. So, cyto-CD3 I'm not using as a gating marker, because though it is specific, there are some early T cells which can be missed when I use cyto-CD3 gating, especially in the setting of ETP-ALL. Okay, hence CD7 is more preferred. You see the markers here. So this is taken from a paper from Dr. Prashant Ambare. So expression patterns of various markers in leukemia blast in TL patients from MRD samples. So you find almost like 8.2% of the cases which are showing a heterogeneous expression of cyto-CD3. So when I'm going to use cyto-CD3 as a gating marker, I may not be able to gate the entire T cell population. Only half of them will be gated and taken for further analysis, missing the bulk of MRD. Okay, so I prefer more of CD7. And one more important point, what I want to highlight is 45 intensity in MRD population, T cell MRD population. You see the 45 intensity, it is right in almost 30% of the cases. Okay, so never ever eliminate a population as it is showing CD45 bright. T cell MRD can show CD45 bright expression. T cell MRD population can show CD45 bright expression in contrast to BALL, which is very, very, very rare to show CD45 bright expression. Okay, so take my point. TALL MRD population can show CD45 bright positive. Okay, so do you need a diagnostic phenotype before searching for your MRD? If you ask me, not mandatorily needed, but there are some special setting where you need the diagnostic phenotype just for seeing the expression of CD56 in the blast. The reason I'll tell you, okay, in the subsequent slides. But CD56 expression, whether the blast is expressing CD56 or not, that information is needed from the diagnostic phenotype, because my gating strategy will differ based on that. Okay, so that CD56 is one thing. And if it's ETP-ALL, as I just discussed, ETP-ALL tend to show a relatively dim cyto-CD3. Okay, so if it's an ETP-ALL, I'll not give very much importance for cyto-CD3 positivity to call MRD. Even if it is dim, I would be happy. Even if it is negative to dim, still it could be MRD. So that ETP-ALL diagnosis is needed for evaluating the intensity of cyto-CD3 in MRD events. So that is the reason why the diagnosis, ETP-ALL diagnosis is needed. Okay, so we have seen ETP-ALL cases, right, where cyto-CD3 will be dim or variable. So you can, it may be an ETP-ALL cases diagnosed outside, and the MRD sample is sent to you for MRD assessment. You finally sort out an immature T cell population which is showing cyto-CD3 in a negative to dim fashion, and you are not very happy about it because you want cyto-CD3 to be moderate positive, to call it as MRD confidently, and you may call it as MRD negative.